Welcome to Headaches and Migraines, a comprehensive guide. Headaches and migraines are prevalent conditions that can have a profound impact on an individual's quality of life. This comprehensive guide aims to explore the various types of primary and secondary headaches, elucidate their symptoms, and discuss the most effective treatment approaches. Whether you're grappling with cluster headaches, tension headaches, or migraines, this guide is designed to equip you with the knowledge and tools necessary to manage your condition and find relief. Let's embark on this journey together as we delve into the complexities of headaches and migraines, seeking to empower you with information that can enhance your well-being and quality of life. Cluster headaches, characterized by their intense and unilateral nature, originate from the trigeminal nerve, situated near the orbits or temples. The autonomic component of these headaches accounts for the severe pain experienced unilaterally, often described as burning, squeezing, or stabbing. Concurrent ipsilateral symptoms such as tearing, rhinorrhea, and facial sweating further contribute to the distinctive presentation of cluster headaches. It's noteworthy that cluster headaches exhibit a male preponderance, and unlike migraines, there is typically no aura preceding the attacks. The intensity of the headache sensation is often described as intolerable, and the pain may radiate beyond the head to areas such as the neck and shoulders. For preventive measures, calcium channel blockers like verapamil are considered the drug of choice. In acute management, options include the administration of 100% oxygen or triptans. However, it's crucial to note that if the patient has a history of ischemic heart disease, hyperbaric oxygen should be prioritized over triptans to mitigate potential risks. Tension headaches, the most prevalent type of headache, stem from tension or stress affecting various muscle groups in the body. Characterized by an ache often described as tightening or squeezing, tension headaches typically present with mild to moderate intensity and exhibit a bilateral band-like distribution across the head. Unlike some other types of headaches, tension headaches are chronic and non-exertional, persisting for periods ranging from half an hour to a week. Importantly, they are not exacerbated by movement or coughing. While photophobia may accompany tension headaches, the pain is generally less severe than that experienced in cluster headaches. Preventive measures for tension headaches prioritize addressing underlying stressors through lifestyle modifications, stress management techniques, hydration, and biofeedback. In terms of acute treatment, analgesics such as aspirin, acetaminophen, or NSAIDs are commonly used, sometimes in combination with caffeine to enhance efficacy and alleviate symptoms. Migraine headaches, often described as throbbing or pulsating, exhibit a female preponderance and are known for their debilitating nature. While some individuals may experience bilateral pain without an aura, the classic migraine presentation entails unilateral pain. Migraines may be preceded by an aura, which can manifest as various sensory disturbances such as a scintillating scotoma, flickering lights in the visual field. Additionally, a prodromal phase may precede the migraine attack, characterized by sensations like euphoria, depressed mood, or heightened perceptions. Exertional activities can exacerbate migraines, which are often accompanied by symptoms such as nausea, vomiting, and photophobia, akin to other primary headaches. Preventive measures for migraines encompass both pharmacological interventions and lifestyle modifications. Medications like valproate, topiramate, and beta blockers may be prescribed, alongside efforts to identify and address triggers such as stress, dehydration, and specific foods. In acute management, treatment options include analgesics, triptans, ergotamine, and intravenous medications like metoclopramide or dexamethasone to alleviate symptoms and improve quality of life during migraine attacks. Temporal arteritis, also known as giant cell arteritis, entails inflammation of blood vessels, particularly the cerebral arteries. This condition is closely associated with polymyalgia rheumatica and poses a significant risk of permanent vision loss if left untreated. Individuals with temporal arteritis may present with a variety of symptoms, including headaches, jaw claudication, tinnitus, and sudden changes in vision. Physical examination may reveal tenderness or sensitivity along the temporal artery. Elevated erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, levels serve as nonspecific markers of inflammation and may aid in diagnosis. Temporal arteritis constitutes a medical emergency, and prompt initiation of treatment is imperative. High-dose steroids should be administered without delay to mitigate inflammation and prevent vision loss. While a temporal artery biopsy remains the gold standard for confirming the diagnosis, steroid therapy should not be deferred pending biopsy results, given the urgency of the condition. Early intervention is key to preserving vision and mitigating the potentially devastating consequences of temporal arteritis. Meningitis represents a secondary headache stemming from inflammation of the subarachnoid space, precipitating meningeal irritation and edema. This inflammatory cascade can culminate in the classic triad of symptoms: headache, fever, and neck stiffness, nuchal rigidity. Initial diagnostic assessments typically include clinical maneuvers such as Brudzinski's and Koenig's signs, followed by specific blood work and a lumbar puncture to analyze cerebrospinal fluid. In cases where focal neurological deficits are present, a CT scan may be warranted to further evaluate the condition. Timely intervention is paramount in managing meningitis, necessitating immediate treatment with broad-spectrum intravenous antibiotics. In certain instances, adjunctive therapy with intravenous dexamethasone may be administered to mitigate inflammation and avert negative sequelae. Given the potential for serious complications, including neurological damage and death, prompt diagnosis and initiation of appropriate therapy are imperative in the management of meningitis. Pseudotumor cerebri, also known as idiopathic intracranial hypertension, manifests as increased intracranial pressure without a discernible cause. Originally dubbed a pseudotumor due to its symptomatic resemblance to a brain tumor, this condition poses significant diagnostic and therapeutic challenges. A hallmark feature of pseudotumor cerebri is the presence of papilledema, characterized by swelling of the optic disc. Left untreated, papilledema can lead to visual disturbances and nerve palsies, underscoring the urgency of prompt intervention. Lumbar puncture serves a dual purpose in the diagnosis and management of pseudotumor cerebri. By facilitating the removal of cerebrospinal fluid, this procedure helps alleviate increased intracranial pressure and provides valuable diagnostic information. In cases where lumbar puncture fails to ameliorate symptoms, pharmacological intervention may be warranted. Acetazolamide, a medication that reduces cerebrospinal fluid production, is commonly prescribed to manage pseudotumor cerebri and alleviate symptoms. Given the potential for visual impairment and neurological sequelae, early recognition and appropriate management of pseudotumor cerebri are paramount in preserving visual function and optimizing patient outcomes. Brain tumors often present with characteristic headache patterns. Individuals may experience dull or persistent pain that is bilateral and diffuse, frequently worsening upon awakening and potentially alleviated by vomiting. Exertional activities such as Valsalva maneuvers, coughing, or sneezing can exacerbate headaches in individuals with brain tumors, adding to their discomfort and distress. In addition to headaches, brain tumors may be associated with various neurological symptoms. These can include focal neurological deficits, convulsions, mild behavioral or personality changes, as well as nausea and vomiting, reflecting the multifaceted impact of these tumors on brain function and overall well-being.